Hi, this question is from Dr. Waller. Thanks
Yeah.
for giving the talk and having an explanation of this. But I just wanted to ask you if you had any, and if so, what is the experience with dopamine agonists to treat folks that are on addiction, things like bromocriptine or anything like that?
Yeah, so dopamine agonists, good question, and those have been evaluated. One of the things to think about, though, is the nucleus accumbens is one of the most protected old parts of the brain, and so it's hard to get enough of a concentration of a drug in that area directly. And so by the time that you were able to raise dopamine in the central axis enough to have an effect, you were causing a ton of other side effects because of the posterior aspects of the brain where dopamine starts to affect movement disorders. So we were finding movement disorders in those patients that look a lot like Huntington's chorea. So using direct dopamine agonists to try to do that. Now things like bupropion, which is an indirect dopamine agonist, seems to work a little bit, but by itself doesn't have enough of an effect on central acting dopamine to undo the anhedonic depression in patients with moderate or severe addictive disorders. And so when you look at the reason that buprenorphine and methadone seem to be superior in raising dopamine enough to get to that normalization without going above, it's because of the physiology that they present with, which is a slow uptake, and they don't have a rapid peak dose. And so even though buprenorphine is taken up quickly, because it's a partial agonist in that part of the brain, you don't get this disproportionate amount of dopamine that's released. And methadone, because it takes a while for it to actually reach peak value, doesn't have that same effect that you would get from like an oxycodone or a hydrocodone, which has rapid uptake and a rapid bump in dopamine, also with a rapid drop. And so you'll notice that both methadone and buprenorphine have a good steady state with daily dosing. So that's why we ended up looking at those medications rather than direct agonists in the central axis.
Do you find better action with something like buprenorphine or patch or
So a couple of points. So it's the same base drug, right, buprenorphine. And it makes sense that low, consistent dose of buprenorphine for patients, especially in a maintenance phase where we're still working on onboarding behavioral therapies and things, because we find that central axis has the potential to heal in some patients, but it takes 18 months to 2 years for that to start to happen. And the difference is that Butrans is FDA approved for pain and not for addiction, and because addiction treatment with controlled substances is carved out very specifically in the law through the DATA 2000, Drug Addiction Treatment Act of 2000. Only methadone and buprenorphine can be written for someone with an opioid use disorder for the treatment of an opioid use disorder. So even though it's buprenorphine, it has to be one of the approved substances, so it would have to be Suboxone, Zubsolv, Bunavail, or now the implantable buprenorphine, which is probably for patients in maintenance phase. Hopefully, we'll see. The data is still early and it's just FDA approved and just now getting out there. You know, that may end up being pretty helpful for maintaining patients on a consistent dose with almost no diversion because it's implanted.
So we have a question here. If you could, before your question, state your name and your coalition or organization you're with. Thank you.
Hi, my name is Holly Strom. I'm a pharmacist with SaveMed LA, Los Angeles County's Opioid Safety Coalition. And I was hearkening back to the discussion of brain physiology, and I'm wondering if buprenorphine's been tested in things like obesity treatment or gambling addiction or any of those kinds of things where there's probably dopamine issues too.
Yes, so,
Anybody?
and I can answer to one that I know of, but.
Go ahead and then I'll comment.
So the only one that I'm aware of that actually has ongoing research into a new FDA-approved use for it is low-dose buprenorphine for the utilization of depression, for treatment in depression. And that's mainly anhedonic depression, which is going to be more of a dopamine-dependent depression, so that flat affected depression. It's low, really low dose, though. It's 1 and 2 milligrams. And the preliminary data has shown that it's probably effective, but at the same time, it hasn't really come out into bigger form. So there are no meta-analysis or anything like that. It's only drug company paid for stuff, and it should be noted, I think, the drug company that's producing this for buprenorphine is also currently involved in the addiction treatment world as well.
So Andrew, before you start, there's a lot of people in the room who are not clinicians, so if we can just define and not use jargon, that'd be great.
Sure. So We don't have good data supporting the use of buprenorphine for gambling addiction, and the data that supporting use for depression is weak. I would have great concern about using buprenorphine for any addiction or mental health condition other than opioid addiction, because someone who's on buprenorphine regularly will become physiologically dependent on that drug. You're going to put them on a medicine that can be very difficult for them to ever come off. And it may have seemed strange too for some people who heard my talk, because the first part of my whole talk I described how the way in which the medical community prescribed or overprescribed a medicine would ultimately lead to a public health crisis. It can sound kind of strange then to hear that we need more prescribing of another drug in response to the problem, which unfortunately I do believe. But even though I believe buprenorphine is extremely important for opioid addiction, I don't think we should be putting people on drugs that they can get stuck on without good evidence to support their use.
Dr. Rubinstein?
There's actually one really interesting study, and again, these are tiny studies and they're very preliminary, but in one study they actually used buprenorphine for depression co-administered with a mu receptor blocker, an opiate antagonist, because buprenorphine acts at more than one receptor, and they found it's not the mu receptor. So if there is a possibility of being able to use this drug as a treatment for depression, it may be that we can use it with a drug like naltrexone, avoiding the dependency issue and then leveraging one of these other receptors that buprenorphine is acting at. And again, that's just super preliminary data, but I think it's an interesting model for how you might see this drug used.
Okay, and who's next?
We have a question.
I'm Loretta Stenzel. I'm a family physician at Vista Community Clinic and part of the San Diego Safe Prescribing Task Force. This is for Dr. Rubinstein. I inherited over time a lot of patients on very high doses of opiates, and I do try to taper them down gradually to safer levels. But a lot of them are on the long-acting versions, which we're told is a better way to go. So when they're on higher doses, but you only want to taper 10%, so they're on maybe extended release morphine, 60 milligrams 3 times a day, how do you make that switch?
Well, so I would first challenge this idea that long-acting opiates have a benefit. Look in the literature, it's been looked at. There's no difference in efficacy. This is another bill of goods that I really think we got sold without there being much to back it up. So if you look at the risks are actually higher of certain things like sleep apnea and androgen deficiency when you use a long-acting opiate than an equipotent dose, the same dose of a short-acting opiate. So I almost always switch them in whole or in part. So you can take somebody who's on 60 milligrams 3 times a day of extended release morphine and say, okay, I'm gonna put you on 30 milligrams 3 times a day, and then I'm going to give you short-acting, and I often use Dilaudid if I'm tapering. And the reason I use Dilaudid is it comes in 2 milligrams, and you can break it in half. And that 1 milligram of Dilaudid is about 5 milligrams of morphine, roughly. So it allows you to use a small currency, and I think about this sort of the way you would think about money. It's a lot easier if you've got ones than if you try to break 100, right? So I will take either all of the drug and convert it to something that's nice and easy to get that nice, tight 5% or 10% titration, or I'll leave them on some long-acting, then some short-acting, taper the short-acting, then go back, take another piece of the long-acting and replace it with short-acting and continue. It kind of depends on the patient. But yes, that's one of the problems that there is that when you're on these 80 milligram pills, there's nowhere to go. And it's actually, there's data that says 91% of patients who have a non-lethal overdose get put right back on their drugs. And it's because we don't know how to do this, and we don't know how to do this because there's no evidence on how to do it.
And so any other detailed questions about tapering, Dr. Rubinstein will have a breakout session, and she'll be going into that in more depth.
Hi, Kavika Liu, Desert Oasis Healthcare.
we're trying to put together a safe RX with, I think it's Proposition 64, and possibility of recreational marijuana. What role, if any, because I've heard from ASAM, some talks at ASAM and other talks, sort of contradictory things. What role, if any, does marijuana, either medical or recreational, have in management of chronic pain? I know this is a huge question potentially, but chronic pain and or opioid use disorder.
Go ahead.
So this is a subject that I've done a pretty recent deep dive in and am writing some things on. But first of all, marijuana has no place, and I'll qualify this because it's the subsequent chemicals within marijuana have a place. So it's 80 psychoactive compounds. And there are probably 3 that are going to be significantly beneficial to the treatment of chronic pain, mental health disorders, and that. It's just not the one that we choose, which is THC. So yeah, so the CBDs, cannabidiol specifically has a good evidence base at this point for a number of different utilizations, even in craving abatement for patients with an addictive disorder. There's some literature on that. But the problem is that the vast majority of marijuana is selected based on the percentage of THC in which it can get, and we're even moving away from marijuana into just the THC substances like wax or things like that, to where it's now turned into a full-on psychotropic, PCP-like medication or drug for people when they start to get these very high levels. So marijuana is going to be a transient, fancy thing that happens in medicine, and it's never been actually gone through the rigors of medicine. And if people want to smoke marijuana on a Saturday, I don't think many people could really care less, if they want to do that instead of having alcohol. But they need to realize that nowadays with THC, that actually affects them on Monday. Because the way in which it works and the pathophysiology of this, you see 72-hour deficits in what we call non-memory required work, which is like if a pilot gets in and has to flip switches, they do that just out of kind of normal or our automatic drive stuff when we get into our car and we do things without thinking about it. That has a significant deficit even 3 days later. So these questions have to really be answered, especially from the recreational side of if somebody just wants to smoke on a weekend and they have a safety-sensitive job on Monday, that's still a problem. That's not going to be found in alcohol if you have a couple of drinks on Saturday and have to show up on work on Monday. There's zero deficit from that. So first we have to remove the reality of marijuana is not a drug, it's 80 drugs. All right? And so we need to find out which one of those substances within there, which one of the cannabidiols has an effective pathway for helping us in pain, depression, other behavioral health conundrums, possibly even addiction. But for the treatment of a patient with an addictive disorder, it is just another addictive substance. At least the THC component, because of the way in which it cranks up dopamine, like I showed you before. I mean, it's 6 times what our top natural is. So again, there's so much emotional context of marijuana, not unlike addiction, just in the opposite direction. So most of my arguments, or what I would like to have as debates, end up being arguments because people are like, dude, you just don't get it. And I'm like, I don't, what do you mean? I mean, it's like, you're just one of those. And I'm like, those what? Like, I mean, but that's where it deteriorates rapidly from a science-based discussion about what are the chemical effects on the brain, what areas does it affect, does it not affect, where do we have research and what it isn't. So the role is, it's matriculating, but at this point, we're going to find that it's probably the subset of chemicals in there that are not THC that are going to have the most profound effect. And THC is going to be the recreational component of that drug, or what would be noted in a medicine as the side effect. So that's where we're most likely going to be heading toward this conversation as far as medicine is concerned.
So just building on that question, okay, go ahead.
Well, I just want to say it is a conundrum that we don't have a lot of guidance on when you are in the chronic pain space and you have a patient who tests positive for THC on a urine toxicology screen. And again, what I see that I'm concerned about is the gotcha game. That doctors have these patients now, they've all signed these opiate agreements. These opiate agreements are really retroactive consent. And then they say, oh, you're positive for marijuana on your urine toxicology. That means I can stop prescribing opiates for you. And I think that's a really dangerous thing to do. I think do I want my patients who I'm working with to taper opiates using marijuana? Not particularly. I don't. And it depends on who they are, my level of please don't do that. But we can't use that to play gotcha with the patient. If it happens, it has to be treated exactly like you said, it's like a diabetic eating a cupcake. We had a talk, we'll talk again about this, but we can't use that or methamphetamine as a way to just pull the rug out from under our patients without giving them some other kind of treatment.
Who's next?
So we've been hearing a lot of, I'm Joel Hyatt. I'm with Kaiser Permanente and one of the leaders of the Safe Med LA Regional Coalition. Hi, Andrea.
Hi.
So there's been a lot of discussion about, not using opioids, decreasing opioids, et cetera, et cetera. Not a lot of discussion about what I hear physicians asking and patients asking is, well, what else can I use? What are the alternatives? What works? What's the evidence for, something else? Can you guys speak to that? Because that's what I hear coming up most is, okay, maybe opioids aren't good, although doctors will say, wait, if I don't have an alternative, what else have I got?
100%. So I think that let's talk about low back pain. Let's get specific here and talk about low back pain. Axial low back pain without radiation to the legs. There is no drug that's going to help that, right? Anybody in here ever treated low back pain successfully with anything, ever? Right? Look around you. Nothing, not a hand. And I've asked this question a lot. The evidence for that says you need a multidisciplinary biopsychosocial approach and or certain long-term strength developing exercise mechanical changes. And so the answer to that is there another drug? No. Most chronic pain probably isn't medication responsive. We don't really fully understand pain, but the problem is the model says if you have a headache or a sprained ankle and you take ibuprofen, you get relief, right? If you have a toothache, you take ibuprofen, you get relief. But chronic pain is not acute pain that lasts a really long time. It's something different. It's a fundamental brain change that is not elucidated the way addiction is. So we're kind of just waving our hands here. But the best evidence we have says that chronic pain really has to be addressed in a multidisciplinary biopsychosocial environment, which almost nobody has access to, except if you're with Kaiser Permanente. It's a little plug for my organization here. But that's really what has to happen. We're trying, we're approaching this with drugs because that's what we have and that's what we'll get paid for. But it's not the right move. If you give a Tylenol to a patient with chronic axial low back pain, the risk-benefit ratio is going to be wrong because we know it's not going to work. So, is the risk of one Tylenol great? But if the benefit is zero, then it's doing more to the patient than it is for the patient. So, put the pen down. You can't fix this with a drug. And that's the mindset I think we really have to go to for most pain treatments. Are there some new ones? Ketamine is really interesting. We're using that. Lidocaine. There's a lot of things that we have at our disposal, but nothing really effective. And I think the second piece is when you have someone who has, say, a severe degenerative joint disease of the knee, we are waiting way too long. That's an anatomy problem. That's a problem with their anatomy. And any drug you give them is going to cover that up. And we try to push surgery out and push it out and push it out and delay and delay and delay. Maybe we should think about that, right? In other words, I really think that problems with your anatomy need anatomical solutions. And problems with your physiology, you have rheumatoid arthritis, well, we need a physiologic solution. We need to alter your physiology so the disease process is less. But we're trying to do physiologic problems to mechanical, physiologic solutions to mechanical problems and physiologic solutions to anatomical problems, it's never going to work.
You know, I think there's a tendency to think about chronic pain as a single condition, and there's even, I think, efforts by the pharmaceutical industry to think of chronic pain as a disease. I think that's a mistake. Pain is a symptom. I think there are some people with chronic pain who are especially frustrating for primary care docs because you can't find anything anatomically wrong and nothing seems to work for those patients, for example, many patients with fibromyalgia. But I really think we should move away from thinking about chronic pain as a disease or a single sort of syndrome. A patient may have chronic pain because they have spinal stenosis or osteoarthritis, or it could be that the patient has low back pain because they're overweight or they sit at a desk all day long. And so I think really to answer the question, if not opioids, what, depends on really the etiology of that person's pain. I would, you might surprise you that I would say this, but I do think that for some people with chronic pain, there may be a role for opioids. I would say so for a patient maybe with spinal stenosis or osteoarthritis who's really tried everything, if that patient is using an opioid on an intermittent basis, they're using a few pills a month on the really bad day, that might be an effective strategy for some patients. Where I think you get into trouble is when you put patients on extended release opioids. They're on them around the clock. You're making that person physiologically dependent. Many patients will need higher and higher doses. I think that's really where you get into trouble. So I do think, though, that we are underutilizing non-pharmacologic approaches, and we are underutilizing non-opioid medicines. In the push to increase prescribing of opioids, the risks of NSAIDs were exaggerated. One of the things you may, if you were around, you may recall hearing that we have 16,000 GI bleed deaths a year from NSAIDs. And the messaging, it was almost as if opioids are much safer than anything else you can give for pain. And that's totally not true. That 16,000 figure is totally wrong. In fact, the total number of GI bleed deaths in the United States each year from all causes, let alone NSAID-induced, is about 3,000, and only a small subset are NSAID. NSAIDs do have risks. They have cardiac risks. There are some patients who we can't give NSAIDs to, but NSAIDs and acetaminophen are over-the-counter for a reason. In general, they really are safer. In fact, some studies, even for acute pain, they find for renal colic, kidney stone pain, which is extremely painful, if you give a patient in an emergency room intravenous NSAIDs, drugs related to ibuprofen, it can be as effective, if not more effective, than giving that same patient morphine. So I think it's very difficult to answer that question, but what you've asked is what everybody's asking and what primary care wants to know. If not opioids, what? And I don't think there's a single answer to that question.
So I just want to pivot off the medical system and tee off your issue around prisons and jails. And I was wondering if Dr. Waller and Kolodny, you want to talk about this big push to put Vivitrol into the correction system, and what should we do instead? What's the right answer to deal with a high number of people in jail and prison who have opioid use disorder, who are getting released into the community, and what's the best way to keep them safe?
Well, I was just going to say, I don't think it's an instead. I think it's in on top of, because I think that naltrexone has a place in the treatment of opioid use disorder. It's FDA approved for that, and I've had wonderful success with this medication when used in the right patients. And so I think that there is a place for it to be utilized appropriately, but it is not the silver bullet. And so criminal justice loves this medication because it's not being peddled on the street by anyone. It's not found at a drug scene, because it's a $1,000 syringe of medicine. These are just, and it doesn't get you high. It blocks opioids. So it's a great medication for patients who have dopamine and are doing well, but it also can be protective and is shown to be protective in people who are moving from jail or prison and have that time frame to try to get to appropriate treatment. And I've had patients who would get an injection, at the time of leaving so that we would have time to get them into the treatment system. So that because the average time of use between being released and use is less than 24 hours. And so the vast majority of people are reusing when they're getting picked up. I mean, somebody shows up with their drug of choice in the car, like to celebrate them getting out. Let's celebrate, by relapse. Awesome. That's super cool. But that's what happens. And so keeping them safe is really important. And so I think if you can't start a patient on agonist therapy prior to leaving, or they meet criteria for having self-dopamine production and are motivated, then that's fine. But I think the biggest piece is the treatment system needs to move inside of the jails rather than waiting for people to get released from jails and prisons and then getting treatment. And treatment inside, if they go inside and they're not on medication-assisted treatment at a low level or consistent level, they are drug seeking internally, consistently, and getting drugs. I mean, it's not surprising to me that they can get heroin inside of jails. It's not surprising to me that they can get, pills inside of jails, and they do. And so there's still a risk of relapse. There's actually an overdose rate within prison where people will overdose while in prison. So it's interesting to me that a patient who was successful on the outside, was doing well, gets admitted or put into jail or prison, is identified as having an opioid use disorder with no motivational state. Why wouldn't we add a medication that would help to motivate them? One, it would make them actually a better prisoner, and buprenorphine is helpful because it's a single-day dosing med. It's not going to cognitively enhance and do that. And you can do it at low dose, and then the therapy that we could add on, even if it's self-help directed internally, is going to be more effective than the that they're going to hear while they're in prison. The problem is that the budgets are set up so that money would have to come out of the prison budget and is not a part of the healthcare budget. And so once they're in the DOC, the Department of Corrections, all of that money has to come out of what the jail is, and it can't come out of the healthcare money. And so there's a disconnect between what we deliver and the average person delivering healthcare inside of the walls of a prison or jail, generally speaking, is not the highest level of quality, both because the quantity of people they have to deliver care to and the general reimbursement for having that as your job. And so those two things combined means that they don't get addiction expert treatment, they don't get pain expert treatment, and they don't get expert psychiatry treatment. And so what they're getting is B team of all of those. And so medication-assisted treatment, while helpful, still needs to be as a part of a treatment program and not just a pill.
I think I agree with 90% of what Corey said. I think the part that Corey said that I very strongly agree with is, you want to give the right medicine to the right patient. And I do agree that there are patients out there who seem to do well on extended-release naltrexone. We don't have good data that would help us position what medicine should go to what patient, so we're guessing to some extent, and to some extent this is based on anecdote, but I believe that the patient who's more appropriate for extended-release naltrexone is the patient with more mild opioid use disorder or the patient who's been stable for a while. And the patients most likely to wind up in the criminal justice system, in my experience, are patients with more moderate to severe opioid use disorder, the patient who's more likely to be a heroin injector. Send people out the door from prison with a naltrexone injection. You will reduce the risk that they're going to overdose, die of an overdose in the first few weeks post-release, which is good because a lot of people die of overdoses right after release from. But I don't know that you've made any headway, because when that injection wears off, you may have actually increased the patient's sensitivity. Actually, you probably have increased the sensitivity to opioids. So if they pick up again after their injection, they may be at a greater risk of an overdose than if they had just been abstinent because of the way naltrexone works. So I'm very concerned that we're seeing the medicine aggressively adopted by counties and criminal justice system. At Phoenix House programs in, I think it's in Orange County, the county will pay Phoenix House a very significant amount of money. I can't remember, I think it might even be something in the ballpark of $1,000 to give a patient in one of our residential treatment programs to put them on Vivitrol. I think $1,000 each patient we start, maybe even something like that per injection, and yet we'll get no money from the county for putting patients onto buprenorphine or getting them enrolled in methadone maintenance. I've brought this up, and it's not. I think it's really the wrong way to go. We should be trying to get the right medicine for the right patient. And if we're going to generalize in the criminal justice settings, you've got a population that's more appropriate for methadone and buprenorphine, in my opinion.
Next.
Sorry.
Hi, my name is Gail Butler, and I'm representing LA Care and SafeMed LA. I have a question regarding the chronic user of an opioid who begins to develop apoptosis, and they cannot produce the amount of dopamine to motivate them. And you kind of indicated where you have two trials. One group of people, they're not producing much dopamine, and treatment's not going to work, and then you have the people who are producing dopamine, and then treatment's going to work. So that group of people who are not producing dopamine, what do you do for them?
So the ones who, and so this is work done by Elliot Gardner and is extrapolated from animal data, and what he showed is that once you have this apoptosis, it doesn't grow back. And so when it doesn't grow back, you're not going to be able to produce the natural amount of dopamine in your reward center. So with that, you have to augment that. And so augmenting that can happen through a combination of things, but this is why we have a percentage of patients, which we don't know what that percentage is, which will need to be on agonist therapy permanently. And for opioid use disorder, it seems to cause much more severe injury to that area based on that data as compared to even alcohol use disorder or that, but it does seem to also work in that. But the severity of injury to the reward system seems to be greater and takes a shorter amount of time with opioids than really any of the other addictive substances that are out there other than methamphetamine. And so because of that, we're still trying to figure out, who it is that we take off. And I would say that the literature currently lands on the vast majority of people will need to be on it forever. But I have a hard time with that one because I think that we're also delivering really crappy care. And so when you look at what are we doing for patients with addiction and trying to get that reward system jump-started, because there are data that shows that after 18 months to 2 years, you start to actually see that area light up on functional MRI again, which means that motivational enhancement therapy can work and good cognitive behavioral therapeutic inputs and helping them develop their ecosystem around them. But I think where we fall short is thinking that for patients who've had a significant amount of time with a moderate to severe opioid use disorder, somehow magically have a safe place to live and somehow magically have transportation capabilities to get to work, and somehow their neighborhood all of a sudden just became like Disneyland. And so I think the interventions that we need to start talking about for those patients, until we understand permanence of continued medication, I think we're going to have a much higher percentage of patients who have to be on opioids like methadone or buprenorphine for an extended period of time until we work on the social aspects so that when we do start to try to taper these medications, then we set them up for success rather than failure. Because I think now we have some states and some payers that say, well, you get 2 years, good luck. And they're setting these very hard dates, and I think the data is pretty clear. Risk of relapse and overdose is really high if you taper too early, right. And in some patients, tapering at all can be a problem. So
this is the pendulum being pushed by political legal rather than by
the science
by
and data.
Science and
but
data.
I also think the treatment system is really ineffective and bad, and I think addiction treatment overall is heterogeneous. It's still in the dark ages when you start to look at quality assessment, effectiveness evaluation, So these are things that are being worked on from the system standpoint, from AAAP and ASAM and all of these, American Society of Addiction Medicine, American Academy of Addiction Psychiatry, and are really starting to look at what are performance measures we should be tracking. What does value, look like in an addiction treatment? Are we getting good care for patients? Because right now there are places that they can go, and California has a disproportionate number of these, where you can go and you can pay $20,000 a month to sit around a bunch of pretty trees and talk to friends, and then go home and die of an overdose. And so I think that these are things that we have to start looking at and taking a really close look at the field of addiction medicine and paying for really only those things that have evidence.
So we'll have about 10 minutes before we can eat. We won't get to all questions, but just want to remind that we have breakout sessions and lunchtime when our speakers will be available. So next question.
Hello, my name is Cheryl Menace. I'm a registered dietitian with a master's in food science. I don't know if there are any dietitians here, but
Thanks for coming.
yeah, I wanted to just make a couple statements. One is talking about addiction. Food and obesity is probably killing more people than any other addiction. And having said that, I see a huge array of different subsets of patients, from children to crippled seniors, that are not being helped and with their pain and knee surgery, hip replacement, whatever, but their success in their weight loss is greatly diminished due to the fact that they are not getting help with their pain medication or any pain help at all. More so than people that are on opiates. Yes, they do have, excuse me, less interest in food, but there's constipation and diarrhea and things like that. Now I'm going to admit something that I doubt anyone here is going to admit. I'm 65. Yes, I am, but that's not it. I've been taking opioids for, I guess, about 10 to 12 years for ankylosing spondylitis. Extremely chronic pain continuously, sometimes worse than others, but I'm a functioning person. I've been a dietitian for 33 years, and prior to starting the medication, I couldn't even stand up straight. I was just depressed, crying in bed. My rheumatologist talked me into trying it. Took him 5 years. And I did start at a much higher dose and able to get down to 3 times a day. This is the part that really blows me away, is if I take too much, I itch. So my body automatically tells me I'm taking too much. But when I try to cut back, I'm not allowed to get that dosage. I mean, the stigma now with opioids is unbelievable. I want 10 milligram instead of a 20. Oh, no, you can't do that because you are taking 20. I mean, there's never a benefit of the doubt, and I'm sure there are people in the closet that are saying the very same thing. So,
They wouldn't let you take less?
no, would not let me, even though I explained, to the pharmacist, and then it's probably my insurance company as well, that there are days that it's not so bad, so I'll take 10, and I'm functional with that. But I'm not sure if I ever want to get off it because my quality of life has just improved so much. So, I mean, it's really a conundrum, and that's why I'm here. I want to learn what I can do and how I can help my patients, and I was afraid to tell anyone. I feel like I'm a leper. I haven't told anyone, my boss or anybody.
I just want to credit you. I mean, I really appreciate you saying that. I thank you for being honest. Because I know Dr. Rubinstein has something to say about this, but one of the things that CHCF is really pushing is let's focus at the people, the highest risk, high dose, benzos and opioids, people using multiple doctors' addiction, and let's leave people alone if they're doing okay on low dose. But I know you have something to say.
It's all about risk and benefit. The drugs themselves there's no moral value to these drugs, right? They're just molecules, and they have an effect. And in some people, like you, they can be very effective, that sometimes over time that can change. And I think it's important to work with somebody who's really good, who can say, can we tweak this a little bit better for you? Can we reduce your risk over here, right? Bone density is a classic example. In people who use these chronically, they lose bone density. That can be, something that we should at least be looking for. We're not even looking. Right, so WNL, which usually means within normal limits in a chart, actually is standing for we never looked. Right? For most of these risks, we're not even looking. So we're not doing you a service if you have a drug that you're getting benefit from, if we're not even sort of calculating out what the risks are.
Well, maybe because I'm a professional, but I do check my bone density every year. But I didn't even know that the opiates had anything to do with that, so.
You made a really good point about the obesity. It is not unusual for me in working with a patient, say, who needs a hip replacement, but is obese to the point that the surgeons won't consider them. And so they're stuck in this rock and they can't exercise because they have terrible osteoarthritis of the hip. They can't get surgery because of their weight. They're on opiates because, you know, when I see them, they usually are. And I'll say, hey, you know, opiates can cause you to crave sugar, and that can actually be working against your ability to lose weight. So let's check and see if you know, and I will actually say we have to get the hip replaced. You've got to lose weight, and I can actually use the opiates as a motivator for weight loss, and then get the surgery, and then actually, believe it or not, even if it's been years, many of them do come off.
And just to the point of obesity as an addiction, I just want to say that there is data for some people that glucose acts like heroin for them. The dopamine bump is huge for a subset of patients, and the super morbidly obese seem to have a disproportionate release of dopamine in the nucleus accumbens, just like if they were to use an illicit substance. And so the substance that causes a rapid rise in glucose in the system, you know, which is going to be probably on the table I go to first at lunch, is the thing that some people do have no different than an illicit substance addiction, and the data now backs that up.
Great. We have time for one question if it's quick.
Thank you. My name is Grace Magaman. I'm the Director of Pharmacy for the Children's Hospital of Orange County here, locally. You touched on the fact that this is an iatrogenic mess. Really, there is responsibility from pharma, and I know you tried your best to not really go that direction, but we recognize that the part that Purdue played in this whole mess. I think it should also be recognized that the government and the requirement to treat pain and some of the civil penalties that they imposed on physicians for not treating pain and making pain a part of patient satisfaction surveys has all created this desire to treat this. But I guess my question is, what efforts are out there to really push back some of the social responsibility back onto pharma and back onto the organizations that have contributed to this?
So right now we're starting to see litigation. There are counties, 2 counties here in California, I think Santa Clara County and is it Orange County is the other? There are 2 counties that have actually filed suits against opioid makers, Purdue, Endo, J&J. The city of Chicago filed a suit. The state of New Hampshire recently filed a suit. Suffolk County on Long Island. You're starting to now see litigation against the drug companies. Many people know that Purdue Pharma got into trouble in 2007. They paid a $650 million fine. That case was focused very much on the way in which they specifically promoted OxyContin. But what they did and what other opioid makers did, which really caused our opioid addiction epidemic, and I mentioned it, it was this campaign that they launched to change the culture of prescribing that went beyond the education I talked about. It was multifaceted, as you mentioned. It involved the Joint Commission, the smiley faces and the frowny faces, CMS and their HCAP survey questions. State medical boards pushed us to prescribe aggressively. Our hospitals, from every different direction, providers began to hear that if you're an enlightened, compassionate provider, the way to treat, you'll know that you need to prescribe opioids aggressively. So we're finally beginning to see a pushback against the opioid makers. We're seeing litigation. More importantly, we're starting to see conferences like this one. We're starting to see policymakers around the country, including the Surgeon General and state legislatures, all finally recognizing that what's fueled our opioid crisis is the overprescribing. Until recently, the focus was almost exclusively on non-medical use. Let's stop kids from getting into grandma's medicine chest. Nobody was talking about why every grandma had opioids in her medicine chest. So we're finally seeing some push, but the opioid lobby, there was I know we're out of time, but there was a really good report published a few weeks ago in the Associated Press. The opioid lobby, in their efforts to block controls on prescribing, is spending, I think it was something like 12 times what the gun lobby is spending. So they're blocking state legislatures and the federal government from any kind of effort that might result in more cautious prescribing.
So thanks to our panel.